She is the president of the Kenya Psychiatric Association. Dr. Good morning.
Good morning, Eric, and thank you for having me.
Thank you for joining us today. There's a lot to unpack, and there's a lot of very many things to deal with in terms of how society views suicide, how doctors such as yourself view suicide, how the law views suicide.
Right.
So getting into that conversation, we first start with the day's quote. Janet, we call her Jan Wama quotes. She is going to give you a quote, something that was said by somebody many years ago, and let's see whether it makes sense to you today.
Okay.
I've owned the name. You may accept. And also just to mention that in as much as the conversation might be triggering, but it's very, very important that we have it. Mae Jemison was the first black woman to travel into space 33 years ago today. And this quote is from her during a speech that she made around that time. She said, "Never be limited by other people's limited imaginations." Do you agree?
Indeed.
Yeah.
Yes, that's quite relatable. Yes.
Sometimes people project their limitations on you.
Exactly.
Yeah.
Yeah.
I always try and look at the other side of this, some of these quotes. So sometimes somebody may,
I know.
somebody may actually be giving you counsel, wise advice, but you choose to stay hard on your position, and you call it their limited imagination.
But you try all the same, even if you fail. If you were certain.
Kama ulikuwa umekuwa warned.
Warned or cautioned, or either or.
Nilikuwa nimekuwarn.
I think it's
But
when it's
you
someone
call
trying
it
to
my
limit.
limited.
Yeah.
So he's like, there's a thin line
it's
between.
your personal interpretation.
That it's
you
a
know what,
limitation.
Mariam, listen.
Don't go to space.
Mariam,
Don't go to space.
that is your limited imagination.
Yeah.
Okay?
Yeah.
I want to enter into this fire.
No.
All right? Just because you think that nobody has ever walked into fire and walked out alive.
Right. Doesn't mean I can. Yeah. I see your point. I know where they were coming from.
Yes.
Yeah, of course.
Yes.
Yeah.
I see your point, though.
Yeah.
What's the line between counsel and limitation? Yeah. Advice and limitation.
Let's ask somebody who has actually studied minds.
Right.
No, I believe everybody has their own, whatever intentions they have been advised either by somebody else or by their own principles. So it's not good to limit somebody because we have also our own abilities, our strengths. Counsel is not bad because we don't know it all, even ourselves, in our spaces as medics, in your space as your journalist and specialist in media. You don't know it all. Sometimes you have to reach out to other people to advise you. So maybe both sides are right. But again, don't limit yourself again because every dream is valid. Everybody's ambition is valid.
That's a good one. That's a very, very good one. So, Doc, you are the president of the Kenya Psychiatric Association.
Yes.
And I know you're basically just, psychiatrists, but there are other people in the space of mental health.
Yes.
Just for purposes of information for everybody, who plays a role in the mental health space? Who else apart from psychiatrists?
Yes, I think it has been confusing for a lot of people. They think that we are the only players, but we have actually a definition of who mental health professionals are by law and by the Mental Health Act, that it spans from medical social workers, counselors, psychologists, clinical officers who are specialized in mental health. And we have psychiatrists, we have mental health nurses. But beyond that, even general health care workers, some of them are also trained on some elements of mental health. So at the end of the day, we do have that multidisciplinary team that runs the day-to-day treatment of people who have mental illnesses, but also other healthcare workers have a level of training on managing mental health issues. Yes.
So what do psychiatrists do? I mean, at what level does a psychiatrist need to come into my case?
So for you to be a psychiatrist, number one, you're a general doctor first. So you go and study medicine and surgery, and then one day you decide, because of one reason or the other, being unlimited again, you choose that I want to be a mental health professional, and you go back to school and you do a master's in medicine, specializing in psychiatry. So really psychiatrists are medics or doctors who have had now a super specialization now in mental health. And we are the ones that diagnose mental illnesses. We treat mental illnesses. And there is a variety of ways of treating mental illnesses through medication, through some interventions that are beyond medication, like what you call electroconvulsive therapy, through psychotherapy also. You know, people think that psychotherapy can only be offered by psychologists, but we also do train on some element of counseling and psychotherapy, and also other behavioral interventions.
Okay, so usually is it about, by the time somebody has been referred to a psychiatrist, oftentimes is it by that time you've seen a psychologist who's made the referral, or is it sometimes in some cases it's straight to a psychiatrist? Just to Eric's question, when does it come to your attention? When do you then take on a patient?
So ideally, that should be the path, that you've been seen by maybe a primary health care worker, a medical doctor who is non-specialized in psychiatry, a nurse, a psychologist, and they refer upward to the specialist. But in our system, because of the paucity of knowledge, the lack of specialists, the lack of even, services at primary healthcare level, you find that most of the times people go directly to the psychiatrist. And sometimes you're the one who end up referring backwards and say, maybe you need to go see a psychologist. Yes. Again, we are very few. So you find that a lot of times also you find in areas where there are psychiatrists, the referral system is already in place and you're told, start at a lower level, go to the psychiatrist. But you know what happens in our system? Yes. Most of the people who are going to see psychiatrists are extremely sick. They are very sick, and therefore they go directly now to the specialist. It's like when you're bleeding and now you're going straight for surgery. That is what happens in our system. Rarely do people go when they have very early signs and symptoms. They come when they're already in the advanced stage of mental illness.
Right. And that's a problem that is mirrored again just in healthcare as a whole. And I think that's what it was a good question so that we can thread, because it's the same reason. A flu and you're at KU, teaching in referral hospital. But I'm thinking through, you've said there's very few of you. How many psychiatrists are there in Kenya?
We're about 150 psychiatrists in the country. And remember, not all of them are in clinical practice. So if we were to go by that number, that means one psychiatrist for about 500,000 Kenyans.
And still on Mariam's question, I don't know whether there's data to this, how many people are in need of psychiatric evaluation? I don't know whether that's, because then I want to see then how many psychiatrists to that population of people. Does that data exist?
So the data that is there, which is mostly from scattered studies here and there, we don't have one national survey that has actually shown the real picture, but there are several studies that have indicated that at least 1 in every 4 Kenyans at any time of their life will suffer from a mental health condition that requires a psychiatrist. And when you go to general outpatient clinics in any random hospital, about 25% of the people queuing have a mental health need. And if you go to any hospital, 40% of those admitted have a mental health need. So the need is there, which is quite a prevalent issue, yet about 80%, again, have been shown that despite them needing the services, about 80% of them don't get that service, don't get that specialized care that they require.
That's a really big gap.
Right?
It's a huge one.
Yeah.
1 in 4 Kenyans will require mental health care that requires a psychiatrist, not a psychologist, not a counselor, not a therapy. And then there's 150. And of those 150, not all are practicing currently.
And this data again of, if you just walk into any health facility today, outpatient services, right? 25% of those, a quarter of those are there and they have a mental health need. And many of them don't know, right?
They don't know.
Many of them don't know. You're there because you're feeling some type of way and all. You do not know that what has actually taken you to hospital is mental health related.
True.
This is what led that task force that was appointed by the government to tell the government, declare this mental health a national emergency. The government has never listened to you people. Did it ever listen?
They did, and they implemented
declared?
a lot of, not declared, however, but they did implement quite a number of the recommendations by that task force.
So if we were to thread that and see the number of people who actually have a mental health need at any one point, and then that 80% of them don't get the need that the help that they need, then we are now going to what we were saying. Wednesday we're marking Suicide Day. Let's talk about the rate of suicide in this country. Do we have any records?
All right, so the data on suicide also is quite alarming, and it is rising by the day, where we say about out of 100,000 Kenyans, we get 11 deaths per year. That translates to about 4 deaths by suicide in a day in our country, and majority are youth.
Say that again. Say that data again.
So 11 out of 100,000 Kenyans.
11 out of 100,000, okay.
Yes,
okay.
Per annum, which translates to about 4 deaths by suicide every day in our country. And remember, because of issues around stigma, about the legal issues we raised earlier about the, suicide being criminalized, they're still quite underreporting. And these are global phenomena, because if you look at this, the other countries, it's more or less the same. But in our country also, again, we don't know the actual picture, because the reporting system, again, is a bit fragmented. And people are afraid to report because you don't want to say my person died by suicide, because back in our villages, you know how the culture is. Then again, when somebody attempts suicide and is taken to hospital, whether they survive or die, you'll find that because of the legal aspects, they will still not be full reported. But at present, that is what we are working with.
That is a crazy statistic. Before we even interrogate this further, I want to start with the language around suicide. In the last few years, we've seen a shift in saying it's death by suicide, not committed suicide and things like that. Explain why that language shift was important.
Well, mainly, if what Eric raised earlier, that there is a section of the law, the Penal Code, Section 226, that actually criminalizes suicide and states that if somebody attempts to take their own life, they are guilty of a crime, and they can be imprisoned for 2 years or fined, or both. However, the High Court ruling on 9th of January that it is that section of the law is unconstitutional because it violates quite a number of rights in the Constitution. That law in itself implicates that somebody suffering from a health issue is committing an offense. Yet you're sick. If you're diabetic and your blood sugar level rises, you're not committing a crime because you ate a birthday cake. You did not commit a crime. You just suffered from a change of your blood sugar levels, and you need medical attention. So when somebody dies from diabetes, you don't say they committed death through eating too much sugar. So it's the same thing. So when you say committed suicide, then you're saying they committed an offense. It is death by suicide. So they died by suicide because suicide in itself has been recognized as a health complication. So that is why we are moving away from the language of committing, so that we remove the legal aspect and bring in the health aspect. And this will, the community will become more compassionate of persons who are dying by suicide, their families, and those who even attempt suicide. We bring in now that empathy, that compassion, and that health outlook.
Thank you for breaking that down. There's another word that people also use, which is unaliving themselves. Is this a sense of, is there a censorship aspect that is also coming into this conversation, a fear of the word suicide? What have you observed? Because in certain spaces, again, there's an encouragement to not use the word. What have you observed, and why do you think perhaps that's also something that's coming up in terms of conversation?
Yes, I think I've also observed that in the social spaces. I think people want to be more socially acceptable and not feel like they're triggering others by using the word suicide per se.
I think the platforms are also sensitive.
That's
Right.
also another
as well.
Yes, yeah. So
TikTok
being
specifically.
yes. So maybe that is also because of a lot of conversation that have gone into educating the public about being sensitive. They are using words that will not be triggering to others. But saying that somebody died by suicide in itself should not be seen as if it's a trigger. Because if we do not, we again hide the conversation and say the realities, then again we are hiding the truth and will not handle the issue head on. So it is important to actually accept that this person died by suicide so that you can start doing something about it and can be alert that were there signs we missed?
Yeah.
Is there something that could have been done in case in future you encounter the same situation?
So, Dr. let's get into that difficult conversation. By the time somebody is at that point where they die by suicide, what are the steps that lead them there?
You will be surprised that most of the people who end up dying by suicide, they have talked to somebody about it.
About what?
About the intention to take their own life. They have maybe even shown signs, they have written maybe a note, they have tried it in the past, they have expressed feelings of hopelessness, helplessness, feeling like they need to give up in life. There are some subtle signs, but maybe people missed it. In our society, like maybe in schools, people will say, this person is just attention seeking at work. But there are some changes maybe may have been observed. I'm not denying that there's a fact that there's some people who impulsively take their own lives, that it comes, the trigger comes, and they do take their own lives. However, you will see signs. Somebody will start saying, I don't feel like I want to live anymore. I feel like my life is not worth living. I feel hopeless. I want to kill myself. And then maybe somebody did not take it seriously. Somebody did not do anything about it. Somebody did not listen. And even the person themselves, they did not seek professional help. So they carry on this. And maybe they attempt the first time, they attempt a second time. So previous suicide attempts are always a very high risk indicator of the possibility of somebody dying by suicide. Somebody talking about it, again, another high indicator. And of course, somebody with a pre-existing mental health condition, a family history of someone having died by suicide, and someone who is going through very highly stressful situations. Those should be some of the warning signs that indeed this is a risk factor.
So let's look at it from both sides. From the audience, the person who's hearing, you coming to say, you know, I'm feeling I'm at the end of my tether. I could take my own life. I don't see the purpose of living. So from that side, you're just seeing somebody who's giving up, and you're like, you know, encouraging them. No, come on, don't give up. There's still more hope. Where acha, you know, kunywa hii, ama twende out, twende tukatembe. That is from the person who's receiving. But this person who's saying it, what exactly are they going through at that time? Is there something that they are fundamentally going through mentally, from the wiring of their brain, that is actually leading them to utter these words?
You know, the brain is a very interesting organ, Eric, because it is controlled by chemicals that really influence even how you think, how you behave. And sometimes when people think depression is something you can snap out of, but really it's a change also in the balance of those chemicals in the brain. So by the time somebody is getting to that level of depression, there's also a shift in the chemicals that control how your brain operates. We call them the neurotransmitters. So at that point, that person may not even be in a position to understand that I need to take myself to somebody for help. And because of that time, the brain has reached a point to saying, this is the only way out. This is the way I need to guide myself, you know, in the next stage. So that is why now they need professional help. That is why they need somebody to speak to, so that despite even the speaking to, if they need to be medicated, then be hospitalized so that they are given the proper care and attention after proper evaluation. Is this depression? Is this severe stress? Is this trauma? Is this something else that requires medical attention or psychological attention? So there are changes that also occur literally in the brain that influence such decisions.
Chemical imbalances can be hereditary or not necessarily?
Mental illnesses do have a genetic predisposition. So you'll find that somebody who has a family history, strong family history, maybe the first degree relatives, mother, father, brother, sister, you may also be at risk of also having a mental illness in the future. Yes.
And is there an assessment somebody can do? Because what's happening now, because of this awareness, you'll find people saying, I've seen a trend or trait in my family. What does that mean? If you're predisposed, do you take yourself ahead and be like, is there an analysis that you need to do just so that the triggers don't drive you to taking your own life? Is that something that people can do? Do you encourage it, or do you not think that's important?
Well, unlike, let's say, conditions, biological conditions like diabetes, where you'll say, I will check my blood sugar, I'll check my blood pressure, or maybe if you're at risk of breast cancer, I'll go and check the markers. And like that, in mental illnesses, we don't have those markers that you can test. And then again, remember, you can be predisposed, but you do not necessarily develop the condition. So there are also factors that may precipitate you, because you could be in a family, 4 of you, and only one person ends up getting mental illness. Other factors may lead to precipitating you actually developing a mental illness, including misuse of drugs, misuse of alcohol, lack of proper coping mechanisms when it comes to facing stresses. Many things in the environment can also trigger you and protect, and then there could be protective factors for somebody who is predisposed, because maybe they build a good social network around themselves. They do not engage in negative coping mechanisms like addictive behaviors. Maybe they are stable, they have a social family, they have a stable job, and maybe when they see the signs of, I am at risk, they are able to say, I know my father had depression, died by suicide, and now started seeing myself going this way, so let me go seek professional help. So those could be protective to somebody who already has a predisposition.
We're going into a break.
Oh yeah, no, so many
thread, I know.
But it's okay, let's go into the break.
Yeah, let's go into the break and even speak to, there's something here I was reading about male suicide rates in Kenya, significantly higher than female ones, so get into that. And then just get into the what next. How do we stand with people who feel like they're spiraling? What language can we use? What referrals can one make, given that there's a shortage of experts? What can be done? I think that would hopefully be helpful for people who are watching. But we are in studio with Dr. Mercy Karanja, President of the Kenya Psychiatric Association. We are marking World Suicide Prevention Day and talking about mind matters and mental health. It's coming up to 7:30. We'll be back in a bit. Dr. Jermaine Mutua on YouTube says, I worked at a private hospital where a psychiatrist, although he's put it in quotes, a psychiatrist on call was a mental health CEO, charging insured patients like a psychiatrist and prescribing psychoactive medication. Is it possible to differentiate between the two groups, CO
and psychiatrist?
Clinical officer and psychiatrist. Okay.
I mean,
is that an issue? Because I don't know whether he's alluding to the fact that he was posturing as one, but he isn't. And if that's the case, how often does that happen?
And even prescribing
medication, yeah.
So let me speak into that, because we do have clinical officers who have specialized in mental health. And it's a course that is offered by Kenya Medical Training College. So we do have clinical officer psychiatry, or in psychiatry. And it's a recognized course. And therefore, they can prescribe, they can see, but they also have the level of where they are required to refer to a psychiatrist who is a medical doctor. Yes. So it should not be alarming as long as they have the qualifications. We do have, the same way we have clinical officers who have specialized in pediatrics, in anesthesia, in dermatology. Yes.
Yeah.
Thank you. That's a really good thing to note. I can see why maybe they may have panicked, because you're thinking someone is posturing as a psychiatrist. But yes, they are clinical officers who are specialized in psychiatry. Getting back to the conversation, I had so many questions. I wanted to start with the baseline. Normal is very hard, and I use that word very loosely, right? The baseline is very hard. It's something that's very hard to know. So red flags as far as mental health is concerned. And how do I know that this is something that requires me to, I don't know, go exercise and breathe and just chill, or this requires a therapist or a counselor, or this requires psychiatric help, whether it's me or I'm looking at someone around me and thinking, So yeah, how do we find baseline, one, and then how do I know how to escalate within now the levels of mental health care?
Let me first start by telling you, you don't have to wait for to see the signs to start acting. You should start by being alert all the time to promote your well-being. You see, the way you're conscious about ensuring you have your weight controlled, your diet controlled, so that you don't get diabetes or high blood pressure. So the same thing, you should have a promotive approach to your mental health. Every day, promote your mental well-being and prevent. Don't just wait for the signs to go see somebody, all right? Then again, the baseline is different for everybody. We have all different phones right here, and we charge them at 100%. But there are some, I hear iPhones, the battery will go low very quickly, and for the others, that the battery will even last 3 days. So we all have different baselines to operate with. But there are some subtle signs that people need to recognize, and you need to recognize in even the people who surround you, that people, when they start changing their interests. Somebody used to enjoy doing something, maybe going to watch soccer with the boys, going for chama, laughing with the girls, but now they're starting to withdraw. Your sleep pattern is changing. When you go to bed, you're struggling to fall asleep, or you're waking up in between. Your appetite is not as it used to be. You don't feel interested in things you used to like. Even body changes. Some people just lose weight and it's not explainable by anything, not an illness. And now we start somebody seeing having behaviors that they were not doing in the past, drinking a lot. So you notice your colleague, they come to work now smelling of alcohol, they are taking many, they started smoking, they're using drugs, they're hanging around a crowd they were not used to. Absenteeism from work. They're always saying excuses of, oh, I'm having this problem, I need to be away. So the absenteeism that is not explained, that is unusual. And then, no, it's not because you coughed, but just some ailments. Every flu that comes by the office, you're catching it. You're always feeling ill. So those, and that is why I was saying 25% of people who go to general outpatient, they don't know. They may be suffering from anxiety. And people think that the common illnesses are the psychosis, the people say that they are confused and they have behavioral issues. The most common mental illness is actually depression. It is anxiety, it's post-traumatic disorders, it's substance misuse. So before you even see that psychotic person who people say anaokota makaratasi, before you even reach there, there's that anxious person who they're always biting their nails, they're living like in fear, they can't sleep, they can't stay still. So those are some of the things you need to notice and be alert to, and ask yourself, do I need to speak to somebody, or is there something that is affecting me in my space? Am I going through some trauma? Am I going through some stress? Or is it a mental illness that is onsetting and now I need to seek help?
And I know you had talked about it, but then the graduation, right? Are there cases where indeed this is something that maybe I need to see a psychiatrist immediately, not a counselor who then refers me, and so on and so forth?
You can see a psychiatrist even at the first time, because we can be able to evaluate and refer you back to the other services. So there is no deterrent for you to see a psychiatrist as a first contact, as a specialist, all right? Because they will be able to evaluate you and say, this is a case I'm going to be able to handle, requires my specialized care, or I will refer you to a psychologist, because we work collaboratively. Actually, mental health is not handled by one person. We work as a team. We have a counselor, we have a social worker, we have the psychiatrist, and we also work with the family and the community, because we have to reintegrate the people back into their community. But there are some cases, like if you feel, or if you sense somebody has suicidal thoughts, suicidal behavior, suicidal attempt, that's a red flag. That is somebody who needs immediately to be linked up with a professional, because that is somebody who is in immediate danger to themselves So that is an urgent issue. It's one of the psychiatric emergencies that we refer to.
So how do I report that? So if I actually notice that this person needs that, they're talking to me, kawaida, they're saying the things that they're saying, what do I do?
So number one,
chief.
if they're talking to you about it, you need to first tell them it is okay to not feel okay. Be empathetic and tell them you need help. I can link you to help. You may not know, Eric, where to take the person, but maybe you've heard of maybe a helpline somewhere that you can get them in contact with, maybe a facility. You know, I know when people are completely, very, very unwell, they are escorted to hospital in manners that are very inhumane, like being tied down, being, you know, in shackles. That indignifies them further and violates their rights. So if they are speaking to you about needing help, connect them as soon as possible. And it doesn't have to be Madare Hospital. It doesn't have to be a specialized mental health facility. Any hospital should be able to handle somebody who has mental illness, because they have healthcare workers who have basic training on mental health. Then they will refer them appropriately. Then the other thing you need to do is, if they're in danger, remove anything that you think may pose a risk to them. If it's alcohol and drugs, remove them from that environment. If it is, maybe there is a pesticide that is maybe within the household and they are likely to use it, remove it. If they want to drive a car, tell them don't drive, because you know they could go and cause an accident with the intention of dying by suicide. So remove those dangers from them. And then, of course, connect them to the relevant help they need.
Yes. I'm glad you've mentioned helplines. I want us to get into that, and I think also understanding what should you hear on the other side, or when does now the person who receives the call make a referral, or are they the ones who offer the counsel? We'll speak to that. But we have a caller on the line from Nakuru. I didn't get the name.
I think Jamim.
Jamim from Nakuru. Thank you for calling. Do you have a question for Dr. Ari or comment you'd like to make?
Yes, I've got a question.
Okay.
That I've noticed that in families or individuals who are high performing academically, those that are gifted in academics, you tend to see a sort of a pattern where family members in that family tend to develop mental health problems. So I was wondering whether do you have a correlation between individuals with the high performing index academically with the maybe predisposition to mental health?
It's a good question.
Yeah,
thank you,
it's a
Jamil.
very
And
good
even
one.
creatives who are extremely talented and active. Yes.
I don't want to tell the bright kids that if you're bright now, you're going to have a mental illness. That's not how it works. But it's really, you know, the pressures that come with some of the spaces we find ourselves in because of what it is that we can do or we are doing. Like when you mentioned the creatives, they work long hours. They will be, they really, there's high expectation on them, people who are in spaces of entertainment. So you might find that people, such stresses, such pressures, there's no preparation on their part to be that high academic performer. Is there somebody who is also giving you support to manage your mental health and to take a pause between the reading and maintaining that balance? You know, we talk of work-life balance when you start working, so that you don't lose it when you go to work. But academic and life balance. So you find a lot of people who are academically very gifted, they will neglect other aspects of their lives that are supposed to be protective of their mental health. And the same thing with the creative, the people in entertainment. So especially people in the entertainment space, they start using drugs so that they can even be better performers when they are on stage. So those are maybe what contributes to these now predisposition to mental health issues and problems.
That's helpful. Before we go to the helpline, demographics-wise, we mentioned earlier that male suicide rates in Kenya are significantly higher than female ones. You can confirm that because it's just data we've picked up. And what other concerns you're seeing or any shifting demographics? Are there a lot more younger people who are who seem suicidal? We've seen men What's changing? What patterns have you seen change? And how do you, what's the word I'm looking for? Yeah. How do you recognize it? And even what are the causes that perhaps this demographic more than the other?
So it is true that we have more males dying by suicide than females. And that is because, number one, men tend to use more lethal means. All right? It doesn't mean that women don't attempt suicide, but men are more likely to use lethal means. They will hang themselves, they will shoot, they'll, means that are likely to actually end their lives. While women maybe may use means that are not as lethal, but they still do attempt to take their own lives. Now, the other thing is because the society, how we brought up our boy child, that don't speak about these issues. So this has made the boy child not talk about their struggle with mental health, not seek help, and they result into drugs, substances, gambling, and things like those. So they're also facing a lot of trauma again in society. Men face more trauma than women, especially when it comes to even socioeconomic issues. So those pressures also have contributed to why we have more suicide, completed suicide amongst men than females. Youth. Suicide is the 4th leading cause of death amongst the youth. So the deaths by suicide among young people are increasing, and it is very sad that we're seeing even children below the age of 10 years. So that has been what is now really saddening to see that this is even shifting to even younger children. And let me say that one of the biggest challenges we're having currently is the social media space, is the digital space, because it is a good space and we can use it positively to even prevent a lot of suicides. However, it has also become one of the areas that is predisposing young people especially to death by suicide, because there's a lot of pressure on social media, there's a lot of bullying on these digital spaces, and this has now contributed significantly to rising cases of suicide and mental health problems.
I'd want to dive into the nexus between social media and mental health and mental illness. But just before that, we have another caller, Farah from Machakos, if I'm not wrong. Good morning, Farah. Sarah. Oh, sorry, Pole. Sarah, good morning. Hi, what's your question or comment?
My call.
Bad line.
Oh,
sorry.
We can't get you.
Sorry, Sarah, we can't get you quite well. There's a network issue, maybe connectivity. If you can maybe move somewhere else, but we can't get you quite very well.
Okay, can you hear me now?
That's better, yeah.
Okay, I have 5 questions for Dr. Karanja. The first question is, Dr. Karanja, you look quite good yourself. How do you maintain your mental, considering you spend a lot of time dealing with people who have mental problems?
Okay.
The second question is about our Gen Zs. They are not, most of them are not afraid of dying. So where do you draw the line between not being afraid of dying and being suicidal? And the third question is about, currently we have health promoters who go from home to home. Are they equipped with counseling also, so that they can arrest the problem from as early on? Because people with mental problems, and Eric, about our education system, is there something in the education system to help children from a young age? Thank you.
Thank you, Sarah. We'll try and get through. I wrote down as many as I could. But thank you, Sarah. We'll try and get through them with Daktari. So maybe we start with the first one. It was, how do you do self-care? Yes.
I really want to appreciate Sarah for lifting my day. That's saying I'm looking mentally well. So thank you, Sarah. And like I said earlier, you have to be intentional. We all have our days when we are not doing so well. Some days we are doing well. So like I said, it's like the battery on your phone. Some days you run out of charge and you have to go and recharge it. If you don't notice when you need to recharge your phone, you'll miss on communication. So you have to be aware of when do you start entering the red zone. So self-care routines, working out, ensuring you sleep enough. I always make sure I get as much as possible, at least 7 hours of sleep.
Wow.
7 to 8 hours of sleep. I hope you do too. You need to sleep. You need
minimum.
Yes. And of course, you ensure you eat a good meal, and then you exercise. I do some exercises here and there. And, having a hobby, something that you look forward to at the end of the day, and hang out with my friends and families. Those are people I make sure I stay connected with, because when I'm feeling low, they're the ones I'll turn to. When I'm feeling high, they're also the ones who are there with me. So making sure you have that social connectedness. So thank you, Sarah, for that. Yes.
The line between not being afraid of death and being suicidal, that's a great question. Because a lot of people will say, I'm ready to die for this country. Does that mean I'm suicidal?
Those utterances are not something we should take lightly, because you see, that means that is somebody who basically has reached a point where they don't feel like their life is valuable enough to protect. And those are the subtle utterances that we ignore. But that should be something that should be taken into, more. You should dig more. Why are you talking about that? And therefore, I may not say directly, I'm going to kill myself, but I'll say things, I don't even know why I'm working so hard. The future looks so, bleak. So it doesn't have to be an utterance that I'm going to kill myself.
Right.
Those could be some of the things. And just, you need to ask somebody, the person, what is driving you to that level? Is it that you've faced so many stressors in your life? Is it that you feel it's hopeless ahead? And when we ignore those things is when it becomes devastating, and we see even people. Sometimes we've seen mass suicide, deaths, or two people who love each other, the one death and homicide case. So we should not take any of those utterances lightly.
Okay.
Yes.
Are health promoters qualified to help with mental health matters, community health promoters?
So sometimes people think that we need to task shift this work to lower levels, which means it's like you're basically saying poor healthcare for poor people, because a lot of services are available in the urban setting. So you're saying let the poor people be served by the lower cadre, meaning then that they're getting poor services because they're poor. I would rather talk of building their capacity to be able to screen, and they can share the task. So all healthcare workers, from their training, including the community health promoters, we equip them with skills at their level to do what they can. And at the community health level, it is identifying the risks and doing some level of screening, and now referring to the appropriate healthcare system. Is there a role of them counseling? Even you, Janet and Eric, you can be counselors. You do counseling every day without knowing you're doing counseling. Listening to somebody, because counseling is about more of listening. And the people may not actually be looking for answers. They want somebody to listen to them. And so they can be able to listen. But then when they find out that whatever I'm listening to requires a higher level of specialization and care, they refer that appropriately. The challenge we have in our system, our care referral system, is quite fragmented. It's not operational. We don't have even those facilities to refer people to, because you find that not all counties have the mental health services. So yes, they should be able to screen, but refer appropriately and offer the counseling at their level, because sometimes you can also counsel and do more damage than good when you provide the wrong information. So we need to build the community to understand and to know what intervention they can offer at what level.
Right. The next question was on counseling at triage level, same way as you go into a hospital and blood pressure, etc. Is that something that maybe we should incorporate into triage, or is there a version of triage for mental health?
Definitely. I am aligned with the fact that we need to make sure that we do mental health screening at every level. Because the same way you even asked, when is the last time you took alcohol? What is the purpose of asking that question? Is it just to tick a box? It is to know whether you're at risk and whether your health condition is influenced by your drinking, your smoking. So the same thing. We should have some basic screening questions. So integration of mental health services at all levels. And I know there's another question on even schools.
Yes,
even
yes.
in schools,
Yes.
even in the workplace, so that we can have a culture where we are not only approaching at it from a care perspective, but also from a health promotion and a prevention approach. So yes, we should screen at every level and refer appropriately or offer services
There was a
appropriately.
question about helplines, but there was also one you asked before the caller.
There was the one for education system.
Okay, education.
She's,
Okay.
Yeah, spoken to it a little bit, but maybe yes, how the education system can help one identifying, just promoting mental health awareness, and then even from a preventative point of view, if there's a way to embed that in the education system.
Indeed. Number one is teaching the learners themselves about mental health. The HIV campaign was successful because we took it to the classroom, we took it to the family dining table, we took it to the community. So the learners also need to know, how do I know when I'm struggling? When do I know when I have issues that are affecting my mental health?
Right.
So literacy in school curriculum. Then the guidance and counseling teachers or the psychologists that are there in schools should also be equipped with skills, and maybe even shift from just having teachers. You encounter mwalimu wa math in class, then you encounter mwalimu wa math in guidance and counseling. Maybe we need to shift from that and actually have professionals who are separate from the teachers offering these services. But schools are a very, very key area. These are teachers are gatekeepers. Teachers spend the most of time with children. And remember, most mental illnesses, the onset is in the age of adolescents and youth. By the time you're in adulthood, your illness may have started very early, and the teachers are the best equipped, and the parents to identify at a very early stage.
For helplines, first of all, how important are they? Because I always feel it's so important to give those numbers because it's a first call you can make in case you're there. But what should people expect? When you call that number, what's the level of counsel you can get? And then where are they limited? So that then you're not also blaming the helplines.
Very true. We have to be innovative. We have to go digital. We have to use technology to our advantage because that is where we're moving to. And COVID-19 taught us that, and we became very innovative. Helplines are important because they can be an immediate response and offer what we call psychological first aid or even online counseling. Psychological first aid is where even a lay person can respond. Like the first aid when you give somebody mouth to mouth on the ground when they faint. So also psychological first aid can be offered. But also, somebody is just looking for someone to tell them, to be empathetic, to listen to them. Remember, most of the times when people are looking for help, they are looking to be listened to. So the caller, the receiver of the caller on the other side will listen and will actually do some counseling and also offer advice that I think you need to go and get more professional help from this. Where are you calling from? We can tell you, we'll triangulate and find out which is the nearest facility for you. And if there's somebody near you, can we also speak to them so that we can see if they can be able to assist you real time. All right? Okay. So it should be that kind of conversation, really.
Yeah.
Let's take a quick break.
Yes.
We'll just stay on for a bit.
If you don't mind, because we still have a few questions.
A couple of minutes. No, we are expecting to have Naomi to join us. And as we have this conversation today, the 4th Nation Mental Wellness Counseling and Counseling Conference is going to be taking place on the 30th of September at the Emara Ole Sereni. More details, as you can see them on the screen. We're coming up to 8 a.m. hosting Dr. Mercy Karanja. She's the president of the Kenya Psychiatric Association, talking about mental wellness in the country. Back in a moment. Properly. We continue our conversation with Daktari for a bit before Degwa Wanaomi joins us shortly. Dr. Mercy Karanja is the president of the Kenya Psychiatric Association. A couple of questions that you wanted to ask before we bid goodbye to her.
Right. She spoke of psychiatric emergencies and also first aid. And I wanted to know what those look like.
So when you talk about psychiatric emergencies, these are conditions that you find a patient is a danger to themselves or to others, and therefore they need to be urgently linked to healthcare services. One of them is a suicidal attempt, because that is an immediate danger to the person. They need to be taken to healthcare because otherwise you may lose their lives. And the other one is even self-harm. Sometimes people may not have attempted suicide, but you've seen children and teenagers who are cutting their wrists and deliberate self-harm, they need also to be linked to psychiatric care. We have people who are what we call psychotic. So you find somebody has neglected their health, their hygiene, they cannot eat, they cannot bathe, or if they are eating, they are not eating what they're supposed to be eating. These are people who are in immediate danger to themselves because they are neglected even their physical hygiene. Then we have severe depression. We have had people who have such severe depression that they will not even leave one spot. They stay in one spot, they can't move, they are not eating, they are dehydrated, they are disconnected completely from reality. Mothers who have had babies and they have severe postpartum psychosis and depression, they can harm their babies. So such cases, and then severe panic attacks. You've seen people who have developed severe panic attacks and they even feel like they are going through a heart attack. So those are people who need to be referred to psychiatric care. We have what we call substance use. Some people get either very severely intoxicated and that poses a risk of them getting overdose and death, like from maybe substances like heroin, but also withdrawal. Alcohol withdrawal. You drink every day, then all of a sudden you stop, and then you face this severe confusion. You're shaking, you get seizures. So those are psychiatric emergencies, and they must be referred because they also need medical care at that point. Actually, alcohol withdrawal, stopping alcohol can actually lead to death if you do not get help when you're stopping to use the alcohol. So some of those things, we refer to them as psychiatric emergencies, and therefore they also need the same urgent care as you give to somebody you find on the roadside bleeding. When it comes to psychological first aid, it's basically first aid as we know it. It's taught even in schools that you see somebody and then they're in distress. Let's say, for example, their purse has just been snatched on the street. You're in psychological distress. You may think it's a small thing, but it's a traumatic experience. You need to listen to them. Just listen to them and then look around and see, is there any other danger they're likely to face? You may need to remove them from that circumstance. Then after you listen to them and look around and you ensure they are no longer in danger, then move them to where the care is available. We do these psychological first aids, especially in disasters, where lay people come to rescue the situation, but then they are not counselors, because remember, counseling is a profession. It's a skill that is taught in schools for many years. So we don't want these people to think now they are counselors and we solve the situation. So look, listen, and link to care so that the person feels listened to. It is a disaster. Then after that, they're supported to access the necessary care. And that is what we call psychological first aid.
Okay. As we begin to wind down, how can you speak to people to reframe how they see those who are struggling with suicidal ideation? For example, in the workplace, somebody who is consistently saying, I'm not well, I can't come up, or showing signs, the first instinct that we've seen a lot of the time is this person is a nuisance or they are wasting resources, etc. How can you speak to how we can reframe that thinking? What would you want to say to people who believe that right now? They say, how can you speak to them to reframe? How should they start to see this person? Because I think that can influence policy. It can influence how you create a safe space. So how can you tell them to reframe their perception?
So number one is the words we use. Even when you talk about somebody with mental illness, even the words we use on a day-to-day basis, they're quite stigmatizing. So instead of saying this somebody is sick,
we are cheesy.
You see such language. So people even don't feel like coming out because they'll be labeled immediately, and that label is likely to follow them all the days. All right. So the language that we accept that this is not just quote unquote madness; it's actually illness. And then tell them it is okay not to be okay. We all struggle. We all face. Homa ikikuja inachapanga kila mtu. Everybody goes through the flu. So even you someday you'll go through moments of struggling with your mental health. So it is okay not to be okay, and therefore it's okay to talk to somebody. And it's also okay to be okay. So let's make it be normalized talking about mental illness. Normalize talking about our feelings. And it's not a sign of weakness to feel a certain way, to feel overwhelmed, to feel like you cannot, cope with the stresses that you're facing at that moment. speak about it. Because without speaking about it, nobody will be able to offer you help. Then remember also, these people do not need, when I say I have a broken leg, you don't say go home and rest. No, you say you need to see a doctor. So it's the same thing. Don't tell them, snap out of it. Let them get professional help because it is available. And when we become compassionate, empathetic, and we listen, people will feel it's a safe space to talk about the mental health struggles and mental health issues, and therefore you'll find even more people are likely to seek help. And this is what one of the deterrents that we've had over the years is stigma. Stigma, and also the law. The law saying that when you try to take your own life, you're committing a crime. So people shy away from talking about it because I don't want to go to committee for something that is health related. So again, making sure that our laws are favoring that conversation and educating people in the community a lot. And then ensuring that the services are there. Because you cannot tell people go and seek help and the services are not there. Integrate this conversation, integrate these services at primary health care, establish workplace wellness programs, and not just physical wellness, but mental wellness programs. Have these programs in school, and that way we'll have a culture where mental health conversations are normalized.
Thank you.
You just segued into like the last question, because Jano, yes, I remember what I wanted to ask. The question was, how do you evaluate the mental health of a nation? And now the actual last question is, how do you fix the mental health of a nation? I know it's a big ask, but yes.
I believe when there was a task force on mental health back in 2020 that produced a very comprehensive report on what is affecting us as Kenyans. What are those issues in the society, in the systems, in the investment we've made, the financing. What they gave a very good comprehensive report, and they made recommendations. And in my own space, speaking from the Kenya Psychiatric Association perspective, is we must deal with the stigma, because without having this open conversation, people will not know that it is a problem that needs fixing and being fixed in a public health approach. All right? So community advocacy, awareness creation must be a big investment so that we can do away with the stigma surrounding mental health and suicidal behavior. Then the second thing is integrating interventions into our primary health care as part of universal health coverage, because people with mental health problems also require the same care that other people with other illnesses are getting as part of UHC. And we also need to integrate this in other spaces, school, in the workplace, our families, and our communities.
Very well said. Dr. Ari, thank you very much for this conversation today. We'll invite you and other members of your association, because like you're saying, we've got to address the stigma, so we have to talk about it. We have to keep talking about it. Dr. Mercy Karanja is the president of the Kenya Psychiatric Association. She's been our guest, and we've been talking about all these matters of mental health. Now, the 4th Nation Mental Wellness and Counseling Conference is scheduled to take place on the 30th of September at the Imara Ole Sereni in Nairobi. The theme for this year's conference is improving the quality of mental health services in Kenya. It will be taking place on that day. Peer-to-peer mental wellness support will be provided. We'll be addressing stigma and discrimination. We'll also be looking at innovation in mental health care and technology, also looking at solutions to mental health issues. So all these will be discussed at the Imara Ole Sereni on the 30th of this month. This is the 4th Nation Mental Wellness and Counseling Conference. Among the partners for this, of course, it's organized by the Nation Media Group, Business Daily, Life and Health, and the partners include the Kenya Counseling and Psychological Association and others. So this is something to look out for, and if you'd like to register, you can follow the details there. Mental wellness at ke.nationmedia.com. That's mental wellness at ke.nationmedia.com. Email that, or you can call several numbers that we are showing on the screen. One of them is you can call Lavender on 0726 432 974. That's 0726 432 974. This conversation has also elicited a lot of conversation on social media, right?
It absolutely has. Still Mike the One says this is one of the most powerful conversations and discussions. It needs to be talked about. I am a huge advocate of men as well, Still Mike the One, because as that Dr. mentioned, there is stigma. And there is data to show that a lot more men are taking their lives. And I think society's stigma, not enough spaces for them to be able to speak about the issues and the pressures that they face. And many times as we talk about creating safe spaces, I think it's really to be intentional about it. And when we say, it's okay, I think we need you to talk, are we listening? Because a lot of the time we encourage people to talk, we'll encourage men to talk. Are we creating that safety for them to talk and not face further stigma from when they open up about what they're dealing with? And I think there's a very big issue there. We need to receive that information from them without stigma.
That's a good point. I was also thinking of threading through, and maybe we'll have Dr. back for this. The nexuses, what's pluralia nexus?
Yeah, nexus.
Nexuses, nexi is between
Radius, radii.
Those ones. Mental health and alcohol and drug use, mental health and gambling, mental health and. Are they precipitating factors, or is it, is it cause, or is it result of, those things? And then perhaps, I think that speaks then to the general psyche of the nation, because we do see, really high alcohol abuse numbers, drug use numbers as well. We're seeing an increase in the levels of suicide, especially among young men. Same statistics applies to gambling. How do those things play into each other?
That's good.
Yeah. Is one an indicator of the other? Is one a cause of the other? Is one an enabler of the other? And so on and so forth.
Yes.
Okay.